Hey guys, and welcome to episode 139 of the OCDStories.com podcast. Now, in this episode, I interview Michelle Massi. Michelle is a therapist based in Los Angeles, and we discuss many things on this episode. We discuss compassion, some of her tips and strategies for you guys to be more compassionate to yourselves. We discuss ERP, exposure and response friendship therapy, so advice for when starting ERP, advice for sort of midway through the process. I ask her the question about as some people start to, recover, reduce their symptoms and the compulsions, and they get more time back. Some people report feeling guilt or shame about the lost time, lost opportunities, what OCD may have taken from them. And I wanted Michelle to address that, which she does. We talk about living with uncertainty, how her view of treatment has or has not changed over the last 3 years. What she noticed about her clients who recover much quicker. I think this is always an important question. And then the sort of usual fun questions at the end. So I enjoyed this episode. I think you will too. And without further ado, here is Michelle. On the podcast today, I have Michelle Massi. Michelle is a therapist specialising in the treatment of OCD and anxiety disorders. As well as working in private practice, Michelle also works at the UCLA Adult Intensive Treatment Program. Welcome to the show, Michelle.
Thank you. Thanks for having me.
No, thank you for coming on, and it was great to meet you in Washington.
Yes.
And I got to see, one of your talks, but also a support group you co-facilitated. I managed to get up at 7 a.m. when it was starting. So the first question then is what made you want to become a therapist, and then what made you want to treat people with OCD?
So I think my story is a little bit different in terms of what made me want to become a therapist. I took a psychology class in high school and really enjoyed it, and so decided to major in that in college. And then when I was in college, I realized that you really can't do anything with a degree in psychology unless you go on to a master's. Yeah. And I thought, that sounds great. I didn't have any other things that I wanted to do. And so I applied for grad school and really found that in my grad program, I quite enjoyed the whole aspect of it. And I had actually had no experience prior to college with therapy. I didn't go to therapy. I had a brother who was in therapy, and I was always jealous that he got to go to this, what I thought was like somewhere where he would go and get to complain about me for a whole hour every week. Yeah. And that was my experience with therapy. And then OCD, it kind of just fell in my lap. After grad school, I found a supervisor who his specialty was anxiety disorders. And so that's where our, most of our referrals came from, was the anxiety disorder clinic at UCLA. And I just fell in love with anxiety and OCD because I always tell people the story, and I don't mean to demean it in any way, but I used to work in camps and work with kindergartners. And at the beginning of the year in kindergarten, these are kids who don't know really how to do anything. They're 5. And by the end of the year, they've learned how to read and write. And they've probably already learned how to write, but read and tell time and count money and tie their shoes. And they're sort of this whole new person. And for me, what the experience with OCD and anxiety was with treatment was something similar of teaching people these healthy coping skills, and then seeing this transformation in sometimes a very short period of time. And to me, that was very cool. It's some of the other disorders, it's harder because there isn't a whole lot of change, even when we do different behaviors. And so with OCD, I just kind of fell in love with that. It seemed like the cognitive behavioral therapy is just very me, and I don't know a better way to explain it, but I just gravitate towards it. It's very result oriented, and I like that. So I find it fascinating.
Yeah, no, absolutely. I'd love to see a study on OCD therapists, on their personality types, to see if they're kind of high achievers, high performing, results orientated, because it fits perfectly with the treatment.
It does. And the funny thing is, and I find when I go to the conference, I'm sort of in the minority, but I know a lot of OCD therapists have struggled with OCD in the past. I personally have not, but I know a lot of them have. So that results might be skewed, because if most of the therapists had OCD, You may
true.
see that.
We have to screen for that.
Yeah.
Okay, great. And yeah, you're right. With OCD treatment, there can be such a quick transformation, like you were saying, compared to some other disorders and just people generally going to therapy. Okay, so because you work in private practice, sort of outpatient, I'm guessing, seeing people sort of once a week, and then you also work part-time for UCLA in their intensive outpatient. Kind of what's the difference in how you're treating or working with those people?
In the bare bones of the treatment, there's no difference. But the UCLA program is a intensive outpatient program. So our patients are there Monday through Friday, so 5 days a week for 4 hours a day for 30 days. So it's a very intense, right? Yeah, it's a very intensive amount of treatment. And they get an hour of individual every single day. So whether they like me or not, they're stuck with me for 5 hours every week. They have an hour of group every week, and we've got different groups related to treatment of OCD. So we, it's coping skills group and a relapse prevention group and a goals group, your typical, treatment groups. And then they have up to 2 more hours of exposure and response prevention therapy on site with and everything's one-on-one except for obviously the groups. So there's a lot of attention. And then they're expected to go home and do homework. And so coming back every day or at least 5 days in a row, there's definitely a difference in treatment styles. And of course, this is for the individuals who have very severe OCD, and it's an adult program. We do have a child program as well, but it's separate. This adult program is 18 and over. And so, it's for the people who are really struggling to function in everyday life. So struggling to work or hang out with friends or go to school. And they're sort of at their, last straw. We do require all of our patients to have come in having experienced ERP therapy, and maybe have what we considered failed outpatient therapy, like once a week or twice a week isn't just enough.
Yeah.
Whereas my private practice, I see people anywhere from every other week to twice a week to 3 times a week, kind of as necessary, but for a 50-minute session. Sometimes if we're doing exposures, maybe slightly longer, but it's your typical outpatient therapy. And I do all the things that you do, in a 4-hour period. I try and cram into 50 minutes, which means there's a lot less time for actual in-session exposures. When I work in my private practice, I actually see kids and adults. So, depending on the individual, sometimes I'm doing a lot of exposure in session. Other times it's a lot more of coordination of care and supportive treatment and giving them exposures to work on between sessions. But the foundation is very similar.
Okay, thank you. And is there any, this is just my curiosity, is there any difference in, say, whether I guess how the adult population versus your child clients, how they engage with treatment? Is one more kind of not eager but willing to do the exposures versus another, or is it really personality based?
I think it's really different. Some kids I come in and are just kind of like, I don't need to change. This isn't bothering me so much. It's bothering mom and dad because they're doing all the accommodation. But I also get that with adults, so I think, sometimes the only difference is the person coming to therapy, when it's an adult. This isn't so much true at UCLA. Most of our patients at UCLA are sort of being brought in by family members. Okay. Some of them do want to be there on their own, but I find in private practice, most adults that are contacting me because they're choosing to seek out treatment. I would say with kids, actually, I do get a lot of parents who will call and say, my child came to me and they're really struggling and they asked for help. And so those are the people who are going to be involved. Sometimes I get kids who are like, yeah, no, I don't think this is a problem. And so I think it's both, you see the same thing in both kids and adults. And then I think the way ERP works can be quite scary. And so you always get that like freak out from, again, both kids and adults of like, you want me to do what? So I see it across the board, no matter the age range. Yeah,
that makes sense. And so I know I have a lot of parents of kids with OCD. I'm blanking now. It's one of those days. So for the kid that doesn't want to engage, or not necessarily doesn't want to engage in treatment, but like you said, doesn't feel that it's a problem. It's maybe because they're doing the compulsions, it's currently not bothering them as much.
Right.
How do you work with those kids to maybe get them to see it's a problem? Or do you allow them to not engage in treatment if they don't want to? Is it?
Yeah, so that's where I give a lot of help with the family members to stop accommodations because, I was once working with a child who had to avoid certain places due to contamination fears, or I guess chose to is my word, chose to avoid these places. But parents would literally drop child off at home before going and doing errands because child would freak out otherwise. And so my word to the parents is stop accommodating. Don't drop child off. Go do what you need to do. And if child has freak out, right? Because the child is feeling like it's no big deal because everything's being accommodated. So that's where I do a lot of family support. And then, I was recently working with a child who believed they had OCD, and we worked on all the things that they thought were wrong. But then I found some contamination stuff, and the child was like, this isn't an issue. I don't have a problem with this. I don't mind that I wash a little extra. It doesn't interfere in my functioning in any way. And so I finally just turned to the parents and said, you know what? I would rather release them, have them stop therapy at this point and come back when they're ready and come back when they want to engage, because I don't want to freak them out or get them to a point where they don't like therapy or they don't trust me or trust another person. I want them to have a good experience.
Yeah, no, that makes perfect sense.
Yeah.
Kind of a bit of a balancing act.
Yes. Yeah. It gets exhausting when you're smacking your head against the wall all the time and, there's nothing on the other side.
Yeah.
Yeah.
Okay. So at the conference, as I mentioned earlier, you ran the Compassion Collective, which was a support group each morning with Kimberly Quinlan.
We did.
Yeah. So I guess the question is, what strategies do you have for the listeners that want to be more compassionate to themselves?
Well, this is totally Kimberly's wheelhouse, and I was like following her. It was an amazing experience. I talk a lot in private practice about self-compassion and just accountability as well. But there's that balance of, I'm choosing to engage in these behaviors, and everything's not going to go right every time. We're not going to be able to just cut off all compulsions. And so being able to have compassion for yourself when you didn't do it or things didn't go the way you expected them to go. I also talk with parents a lot about having compassion for themselves, because oftentimes they'll come in feeling so guilty for accommodating or so guilty for like getting stuck and, oops, I gave into a compulsion this time. And so it's a lot of compassion of, giving yourself a chance, knowing that we make mistakes and trying to make less mistakes in the future as we're moving forward. So, we're still going to make mistakes, but as long as we're making more progress than mistakes. I talk a lot about that. And something that Kimberly taught me in the group was about common humanity. And so I've been doing a lot of a reading, and I found this amazing new workbook that I'm reading through right now. And it talks a lot about the common humanity, and a lot of my clients feel that they are so different because of their OCD. And so really acknowledging that everybody struggles, and everybody has something on their plate that is difficult for them. And bringing back the common humanity of, I'm not an awful person, or I'm not stupid, or I'm not a failure because I've engaged in all these compulsions, but everybody struggles, and how can I put one foot in front of the other?
Yeah, I like that. That's really good. And is the book relevant for kind of anyone, or just see if you want to name drop it?
I am happy to name drop it. It's called the Mindfulness Self-Compassion Workbook. It's I think her name is Kristen Neff. It's the person who is I don't remember if it's Kirsten or Kristen Neff, but it's a brand new workbook, literally came out last week. I pre-ordered it, and I find that it's really helpful. It just talks about mindfulness and self-compassion, which I utilize so much in therapy. I'm only about a third of the way through the book, maybe not even, maybe a quarter, and so far I'm loving it. So I highly recommend it.
Yeah. No, thank you. Is this one of your 5 books you have on the go?
It is. I've got that one, and I'm reading a anxiety book for kids because I'm working with a kid who has panic and anxiety, and I just want to see if this was a different book than things I've read before. I think I have another workbook related in there too, but I can't remember what it is. And then I have some fun books.
Okay, great. Yeah, you have to mix it up, otherwise it drives you crazy.
Yes.
Okay, so a couple of questions around ERP now. Very general, but obviously starting ERP is scary for most people. So when you're working with a client who's starting ERP, obviously you explain how it all works, but is there any nuggets within that you feel that may be different from how other people explain it, or you feel that really creates like a light bulb moment for your client?
Yeah, I mean, it's hard to say whether other people describe it differently because I'm not in session with other therapists. But I think I probably describe it fairly similarly. And I really start with all the basics of, what OCD is. I do a lot of psycho ed before I start treatment, what OCD is. And I talk about, well, ERP may be really scary, and I think I focus a lot on how hard ERP is. I understand that it's a difficult thing to do. I understand that it's really painful, but I really focus on values and what we're missing in our life because OCD has taken over or because we've handed over the keys to OCD. And so, what is important? What do we want to get back in our life? And just sort of validate how difficult ERP is. And let clients know that, first off, there's nothing I'll make them do that I myself won't do. But I do add the disclaimer that there's pretty much, I'll do anything. The only thing I won't do is lick the bottom of my shoe, which I think it was David Tolan. I saw him do it on a TV show. I'll lick my hand and touch the bottom of my shoe and lick my hand again, but I just won't lick directly onto the shoe. But I will pretty much do anything else. Yeah. So, but I remind them that my job is, as their ERP therapist, my job is to push them to do the things they don't want to do, the things that are super scary. So that's, and I think I do it all with a smile is what I tell them. And so maybe that makes it easier to do the ERP.
Yeah, no, I agree. I think the smile's an important one because it's a scary treatment. So if the other person in the room's smiling, it kind of takes some of the sting out of it.
Yeah.
Okay, cool. And so I've got a question here about, I know sort of midway through treatment, some people can get not complacent, but maybe complacent when they start to see progress. It's easy. I know in my own life, I take my foot off the gas when I feel I'm starting to get success, and that's ultimately when I should put my foot down more. Is this something you've noticed? And if so, is that just a conversation you have with someone?
Yeah. And I don't think it's necessarily just related to OCD, because I've seen it with clients who have schizophrenia and clients who have bipolar. It's like, ooh, I'm feeling good and I'm just good enough. I can stop my medication, or I'll see it, with OCD therapists of like, I'm okay with having this much. And obviously listeners can't see my fingers, but this much OCD, I'm okay with doing these compulsions. They don't bother me so much. Yeah. And what I try to remind clients is, for those of them that remember back in the day, California, like nobody smokes anymore. But back in the day, I remember going to a restaurant and them asking, do I want the smoking section or the non-smoking section? And I remember this one particular experience where they put us in the middle of the restaurant in the non-smoking section. It was literally 4 tables of non-smoking, and then everybody else around us smoking section. And it was like literally the table right next to me was smoking, and I'm like, like the smoke still comes in. And that's to me how OCD works, is that when you are saying to yourself, I can compartmentalize my OCD, we really can't. It's, it starts to snowball. And like you said, as you start to be complacent with treatment, that's really when you need to sort of ramp things up. And I remind clients, because what happens, especially when patients leave our OCD program, they've been working for 6 weeks straight. They're exhausted. They're like, I deserve a break. I worked really hard. And I remind them that unfortunately, OCD doesn't take a break. It doesn't take a vacation. And so neither can you, because what ends up happening for all of our patients who do choose to take that break, they relapse very quickly because it gets very easy to not do, exposures on your own. And we talk a lot at UCLA about relapse prevention. And one of the things I talk a lot about is accountability, and you as a patient or client sufferer of OCD, you need to practice these things in order to prevent relapse. And it's very easy, if I had a quarter for every time a client came into my private practice and said, okay, so last night when I was doing my OCD homework, because I forgot to do it all week, I'd be rich. And that's really what happens, is that people are like, not doing their exposures on a daily basis. And it's really important too, because OCD, it's sneaky. It's a bully, and it's going to sneak in and worm its way in anywhere it can.
Yeah. No, absolutely. I think that's great advice. Okay. So a question I actually got today, from Instagram, I believe. This person was, and I've heard this many times, so I wanted to address this a bit more in some of the episodes, is as you start to reduce compulsions, whether they be mental or physical, you get more of your time back. And, I talk a lot about values on this podcast, and obviously starting to fill your time with meaningful activities. But the other aspect of that is then some people start to get like guilt and shame come in around the time that's been lost, guilt around missed opportunities and what OCD's robbed them of, etc. I guess, what do you say to someone when they start sharing those emotions around?
Yeah, I'm a really big proponent of giving space for all emotions. I always tell my clients, I can't tell you not to feel guilt or shame. That's your space, but it's also your choice to feel that. And that's where I do a lot of self-compassion work, because it's like we can sit here and we can lament about the past and I shoulda, coulda, woulda. But the reality is you have the rest of your life in front of you. And so let's really try and focus on that. And, when I'm talking to 21-year-olds and they're, all these missed opportunities, I say, yeah, you know what? At least you're 21 and you're worrying about that, because I'm also working with an 80-year-old who's sitting here going, I shoulda, woulda, coulda. And you at least can make changes now and have so much more of your life than that 80-year-old can. And I had the same conversation with the 80-year-old, although I've never worked with anybody in their hundreds, but 86 is about the top. But I really focus on, I also bring in mindfulness actually in this situation, because mindfulness is really about being in the present moment without criticism or judgment. And so when they start, complaining or struggling with the guilt and shame, I really talk about that's not very mindful. And that's not, I ask them, how is this helpful? And so we have lots of conversations around that. And like you said, values, if I focus on this, what else am I going to be missing?
Yeah, really good. I like that. Yeah. Okay, so I'm always intrigued, because side note, by people who are like 80 and still want to recover and don't think it's too late. And I think that there's something very hopeful about that. I'm aware of someone else in Germany who's 80 something, and that lady's going through treatment now, and it's inspiring. Yeah. Okay, so where's my question gone? So is there any advice for just learning to live with uncertainty a bit more?
I think it's through practice, as you're doing exposures and recognizing that you're able to tolerate that. I focus, again, back to the common humanity part of it. I focus a lot about, the reality is nobody has certainty. I don't have any more certainty than you do. And I don't have any less certainty than you do. The reality is we have no control over life. I mean, we can obviously control certain aspects of it, by the way we treat people or engage in things, but we really have no control. I don't have control over, plane flying in the sky or a relationship with somebody. And so it's really about just learning to, through looking at values and through mindfulness, is being able to sit in the moment and tolerate that we just don't know anything and we don't have certainty.
Yeah. I think that's an important one. Is that practice? Absolutely. It's not something you get straight away, but like mindfulness. If you practice it daily, you're going to get good at it.
Right.
And just that acceptance that there is no certainty in anything.
Right.
I think another thing that helps me is if I'm getting really uncertain about something and I'm not tolerating it, I kind of remember, well, yesterday that thing was still in my life, but I wasn't conscious of it. I didn't care. And now it's like it's going to ruin my life. Right. Seeing that can diffuse me a little bit.
Yeah, I like that.
Cool. So how it's kind of, you can answer this two ways, is how has your view of treatment changed over the last 3 years, or what have you learned in the last 3 years?
Ooh, that's a great question. Yeah. I think the biggest thing that has come out of the change in treatment over the last couple of years is the inhibitory learning. So when I first learned about treatment for OCD, it was the focus on habituation. And it's not that I've thrown habituation out completely, but it was, you make a hierarchy, you start close to the bottom, and you work your way through it. And now what they're finding is that you don't need to do that, which is really helpful for my patients who come in, especially at UCLA when we have, the severe symptoms, when everything on their hierarchy is a 10. I know some therapists are no longer making hierarchies. I still like to do it as a roadmap or as a sort of it just helps me organize my thoughts and my plan better. So I still do it, and I still utilize SUDS numbers and check in with clients on how they're feeling and everything like that. But it's not quite as important as it used to be. And so I think that's been the major change over the last couple of years. I think also not so much in treatment what's changed, but just we always talk about, my colleagues and I, about how OCD has evolved. What are the major, not necessarily subtypes, but maybe worries as time goes on, where back in the, when I first started treating OCD still, there was even so many worries about AIDS and getting HIV. That has definitely lessened. Not that I have no patients who are worried about that at this point, but the numbers are totally different. Yeah. Even STDs in general, I don't have as many patients who are worried about that. There's when I happened to go away on my honeymoon right when the Ebola thing blew up. I will not forget that, because I came home and one of my clients was like, "You cannot leave again," because then there was this huge freak out on Ebola, and I remember even a few years before that, the whole anthrax freak out, and so I had many more phone calls with that. Now I'm finding way more phone calls related to OCD related to gender identity and am I gay? Am I not gay? And so I think that's what's more in the media these days. And so that's, and much more in relationship OCD as well. And I don't know if that's more because we know what relationship OCD is now, or just, again, where the focus has shifted.
Yeah, that's interesting. Yeah, you're right. With relationship OCD, it could just be because we understand it now, and before it was getting missed.
Right.
I think that's interesting. The point, because I try and avoid on this podcast, we talk about themes within the episodes, but I don't title the episodes like contamination or homosexual. I leave those out because for me, it's as Reed Wilson says, the content of your worry is trash.
Right.
Or rubbish, as we say in the UK. My wife says trash, it irritates me. Only because she's not American. Okay, so so I try and avoid it where I can. And what you said there, how it's changed with time. If there was such a thing as a subtype, there would still be as many people with HIV fears now as there was in the 80s.
Right.
But there's not. So that shows that the genetic part of your brain that is HIV OCD hasn't disappeared through time. It's where OCD is focusing, right? Right, exactly. Yeah, I mean, when someone's in that place, though, it's hard to kind of drum that message home because... Yeah, and I understand. Okay, so what have you noticed about your clients who recover much quicker?
That's a good question. So I do notice with kids, and I think this was super fascinating. I used to work in the child anxiety disorder clinic at UCLA as well. And I think one of the funniest experiences for me was in working with one of my first clients there. They were doing a research project, and it was a 14-week treatment. So their subjects would get 12 sessions of ERP. And I literally would have a kid come in and over those 12 sessions walk away with 0 OCD. Now, obviously there's no cure for OCD, but literally no symptoms. Y-box score, Cy-box score of 0. And so I was just like, wait, how's that possible? I've never worked with an adult for, 12 weeks and that happened. So what I found was with kids, there's not the other noise in their life that's going on when we're doing treatment. And so, they're not coming in and getting sidetracked by relationships or job or all what I call drama. I always put it in quotes, but drama. So I find that kids are a lot or have an easier time really working through and focusing. We just do ERP and there's nothing else going on. And I see a drop off of symptoms much more quickly. And I always tell, one of the common questions I get when people call me in private practice and ask, how long is this treatment going to last? I always say it varies. But the reality is that if you are doing the homework between sessions, then you will see a dramatic decrease in symptoms within 3 months, But, how long your OCD has been around, are there other factors? I have many clients actually that this speaks to, is that they have OCD and many other disorders, Asperger's disorder as well, or they're struggling with trichotillomania or panic or generalized anxiety or social anxiety. And so as we're doing exposures, they're also interfering in the work that we're doing or adding a second layer. It may not even be interfering, but adding another more complicated layer. And so sometimes it's way more difficult. So sometimes it's the, how good a person is in doing their homework, how committed they are to therapy as to how much better they get, how quickly they get, or how quick I should say. And other times it just depends on the complexity of everything going on. Yeah. Are there other factors?
Yeah. No, so you're right. There's so many things. I think what you said about the kids kind of makes sense for adults as well, because obviously, if you're having to cook for your 5 kids you've got and you've got to clean the house and, work your job, it's hard, right? But I guess it's something to keep in mind of, is there a way I can reduce my life responsibilities or dramas, or can I get other people to help out more because I need to focus on this?
Right. Right. Okay. Yeah.
Cool. So, so let's say you met someone, you're walking around the conference. Well, you probably know they have OCD because they're there, but they come up to you, tell you they've got OCD. They just want one bit of advice. What do you tell them?
Go get treated with ERP. I mean, that, if they haven't done it already, that's sort of my bit of advice is because there really is, it's so phenomenal. There's a lot of disorders out there that even with treatment, people don't necessarily get better. And, if you have OCD and you're doing the golden standard treatment, you will see a difference in your life. And that's the fabulous thing about the intensive treatment program, not ours specifically, but just generally intensive treatment programs, is that watching somebody's life change in a short period of time it's so dramatic and it's so amazing. Going from a patient coming in who can't drive to within 6 weeks driving on a regular basis. So to me, it's go get help. Go do the ERP treatment. And then the second bit of advice that I'd add to that is connect with other people who have OCD. Because again, that's the one other thing that I've seen with the intensive treatment programs, especially ours, because we have that group component. Not all offer the group component, but ours does. And I find that, so many of our patients are like, am I going to have to talk about my OCD? And I said, just give yourself space. And there's such a connection with like, oh my God, they may not have the same exact OCD, but wow, they had the same thought I did. And there's some sort of, connection. And that's one of the reasons I love the conference, because there is that accessibility to other people from all over the world that also struggle with similar worries and compulsions.
Yeah. I think that's so important, is realize you're not alone. And what did you call it? Common humanity earlier. Is that?
Yeah.
And that's similar.
That's a self-compassion
okay.
word that I've totally stolen, but I love it.
Yeah. No, it's great.
Makes you feel less alone.
yeah. That's true. Everyone suffers. Everyone has, at some point in their life, will have their own battle to deal with. And currently this is yours or ours. And
yes.
Yeah. Okay. So if you could pick up the phone and call your 20-year-old self, what would you tell that young lady?
Oh my God. Don't sweat the petty stuff. I think I often laugh. It's actually, I wouldn't change anything, because it's, as my clients will tell you, I share a lot of the stories of my childhood and especially college years with them, because I feel like they're so relevant. And so they've been really helpful to help me engage and have those experiences. But what I often will tell my clients is that I promise you, in like just a few years, this will not be, you will look back and laugh at these situations. And so I think that's what I would tell my 20-year-old self, is just like, this is so not going to be a big deal. And I remember my aunt said some version of that when I was in college. I called home crying about some exam or paper or something. I was really stressed out. My aunt's like, look, 10 years from now, this bio test or chem test or whatever it was is really going to have no difference in your life. It's not going to even matter. So, take a breath and move forward. And that's kind of what I would keep telling my 20-year-old self.
Excellent. And does that test matter now?
No,
okay.
It has, and I laugh because I tell my client, this is a story I tell often, is in high school, I got the chemistry award, whatever that meant. I got the chemistry award. And then freshman year of college, I failed chemistry. And I was originally pre-med. I was always planning to be a pediatrician. And my professor, when I went to go get help, told me that if I didn't get an A in his class, I basically had no chance. He had different wording, but I had no chance at going to med school and surviving. And so I always joke around with my clients of like, well, you're welcome that I failed chemistry, because I wouldn't be a therapist now.
Yeah.
But, I find that like things work out and that, the things that we feel are so important. I remember being in high school and thinking like, oh, I have to go to this one college. And then I didn't get in and I was devastated. And you know what? It probably actually was for the best, because the way my life went, I probably wouldn't have ended up doing the same thing or meeting the same people. I would have been sort of maybe stuck in a rut of the same things I had been doing. And so it's really, I've tried to continue to live my life that way.
Yeah. No, I love that. And I think you're right. If you keep learning from, I'll say mistakes or failures or whatever words we want to use. Experiences, and you keep moving forward, eventually it all comes good. And you, as what's his face, Steve Jobs said in that acceptance speech, you can only join the dots looking back. And but when you're in it, you're like, how is this ever going to work out? And especially with people right now with OCD, that's probably what they're thinking, but it can and it will if you keep putting the left foot in front of the right or vice versa.
Yeah.
Okay, cool. So you've got a billboard in LA. What do you want on that billboard?
That's a good question. I like the 20-year-old question. That was way easier. Billboard. Probably put one foot in front of the other. We can always, everything, kind of back to what I was just saying, everything looks sort of bleak in the moment. But, when we get through it, we can always look back and look at the lessons, but also just recognize like how far we've come and what we were able to work through. But we just have to remember, keep putting one foot in front of the other.
Yeah, absolutely.
So
okay. And is there anything else that I haven't asked you that you wish you could have shared today?
No, I think, it's one of those things I always talk with my colleagues when we're trying to train new students who are learning about OCD and how to do the treatment, and it's always like, oh, what do I need to focus on, or what? And it's obviously always after the fact, that I go, oh my God, I totally missed something totally important. But of course, in the moment, or like when we're even applying for the IOCDF conference and we're talking about like, what are we going to talk about? And it's like, I have no clue what would be a really good, topic. And then the topics come out and you're like, oh, I could have thought of that. Like that would have been easy. So nothing's coming to mind, but I love talking about OCD, and I love talking about the treatment, and love talking with clients who struggle. So that's kind of where I love this passion.
Nice. Yeah, I can see it. And thank you for giving up your time today to come on.
Thank you. I enjoyed it. Anytime.
So there you have it, another episode. I hope it was helpful, and thank you to Michelle for her time. Quick disclaimer, guys, this podcast is not therapy, it's not replacement therapy. Please seek treatment from a trained professional. And until we speak, take care.